Hello, and today let me start this lecture with a few questions. As you can see, the topic on the board is syphilis, a topic which you find you know it. But now I'll ask you a few questions, and let's see if you can answer those questions confidently and you know it all. Let's see. First question: a patient comes to you and her VDRL test is positive. What is the second step that you will do? If the second step, that means the second test also comes out positive, what treatment will you give? What are the signs and symptoms that you're supposed to look forward in a patient who comes to you with a VDRL test positive? What are treponemal tests? What are non-treponemal tests? What is the significance? Titers are given by which test, and which test just gives you outright reactive or non-reactive? If penicillin is the treatment of choice, what are the alternative treatment for syphilis if she is allergic to penicillin? So if you find yourself in a tight spot answering these questions, I think you should follow my lecture very closely today. I have nevertheless time and again insisted upon why infectious diseases as a whole is an important topic and why infectious disease in pregnancy is also a very important topic. So today's lecture is going to try to hover around these important basics, and also would throw the light on some of the basic and important fundamentals of syphilis, something which you should not run around and run from. So let's start with today's topic, syphilis. Let's first give you the topics which I'm going to cover in this lecture. An outline as to what syphilis is. It's a taboo disease. Obviously, people don't talk about it, but you as gynecologists have to speak about it. So let's just first try to speak something about syphilis. How is it, modes of transmission? How is it spread? What is the rate of transmission? And whether it is spread through blood transfusion or not. So get your fundas absolutely clean. Then comes the different stages, which is actually the cornerstone of all these tests and diagnosis. So first we talk about the disease, then we talk about the signs and symptoms, then we talk about diagnosis, and then we talk about treatment. That's how every lecture goes. So then of course will come the diagnosis. Here I'll talk about non-treponemal and treponemal tests. Then we'll talk about the treatment of syphilis according to the different stages of pregnancy, the disease, and then a little word about syphilis in pregnancy. So let's not waste any further time. Let's start with the introduction of syphilis. See, syphilis actually is a sexually transmitted disease. Why do I say that? Is because with the very minute abrasions that are there on your skin, because of every day-to-day chores, you would be having these minor abrasions which you can't even see. We call them microscopic abrasions. If they come in contact with a lesion, a primary Syph lesion, there is a good chance of transmission. Mucous membranes are even more vulnerable to this transmission. So, if vaginal mucosa or buccal mucosa, it comes in direct contact with this primary syphilitic lesion, which we call as chancre, there is a very good source, a very good source of cause of transmission. It's transmitted by a spirochete. Spirochetes are multiple. They have different, categories. Treponema pallidum is one of the spirochete which is responsible for transmitting syphilis as a disease. So what we're looking here is a specific treponem, a treponem pallidum. Otherwise, spirochetes have many kind of, treponems, which cause different kind of other diseases. Okay, but syphilis is caused by treponema pallidum. Let's stick to that, because in postgraduate classes, you are expected to know at least this much. Not more, but at least this much. So as a result of which certain tests are designed. Why we call them non-treponemal tests and treponemal tests? Because not just because this is non-treponemal. They are treponemal only, but they are not specific for treponema pallidum. So the different kind of tests which are available, which I'll be getting to in the next class. Right now I'm just giving you an outline. So these tests, they are designed against the whole family of spirochetes. And this treponema pallidum or treponemal test, they are designed against the specific Syph causing treponema pallidum. So that was the outline. Now, whether it is caused through blood transfusion or not, number one, it's very difficult to culture, the spirochete, because it dies within 30 hours or so if it is on a non-live media. So even if it's kept inside, if it's there in the bloodstream of a person who was infected, suppose you took the blood from a patient who was syphilis positive, which is very unlikely because there are tests which are done. one of which is syphilis test. VDRL is done on the blood that is about to be transferred or what is taken from the patient. So anyway, suppose you took the blood from a patient who was syphilis positive. The spirochetes are there in the bloodstream, and which are more obviously in the lesion, but you nevertheless they are there in the bloodstream as well. So anyways, they will die by the time you transfuse it into another patient, because the shelf life, or let's say the breeding ground of the spirochetes, they need a live tissue. Alright, that said, that means the transmission from blood is almost impossible. But from a live chancre or a live wound, a live lesion to another person with a mucosal membrane in contact, very high chances. The other source of transmission of SIF is from placental transfer. That's called as direct vertical transmission. It does take place through the placenta. It does not stop the the spirochetes from moving from the mother to the fetus. So a positive mother will give rise to a positive baby. But this we're going to discuss in the last segment. Right now, I'm just discussing about syphilis, and I have already included the guidelines of syphilis in my notes, which are there with my students. But I'm giving you a very brief tour so that you are able to understand it better when you're studying it. Now, what are different stages of syphilis? Now, try to understand these things. You have early syphilis and you have late syphilis. All right. Early syphilis, I'm talking about either it's primary, or it is secondary, or it is early latent syphilis. That means if there are signs and symptoms, I can categorize it. If it's too late, if it is complicated, let's say syphilis, it's either tertiary syphilis or it is late latent syphilis. I'll get to that. So first of all, the stages are early and late. In what basis am I saying that? This is usually within a year or so. This is probably after a year or so, but I'm not talking about time over here. I'll come to late latent and then probably I'll speak about the time. Right now I'm talking about complexity. So let's not confuse you. Let's just tell you what exactly it is. So early syphilis was first sign and symptom that you will find in a patient who's presenting to you in the clinic. Is a patient will come to you with a exposed wound, probably in the genital area, whether it is penile or it is in the vulva. There will be a wound called as a chancre. It will be like an ulcer, an open ulcer, which will be there in case of primary syphilis. Primary syphilis, that will be a chancre. Secondary syphilis, that means it's got a little disseminated through the lymphatic channels, through the blood, and it has reached to some other places, but not so serious as maybe the aorta or the brain, because in that case I'm talking about neurosyphilis, which is actually the tertiary form of syphilis. So over here, what you'll find is maybe the surrounding nodules, the lymph nodes have swollen up a little bit. Okay, so that means you're talking about gammas over here. Okay, it has disseminated in the blood, so there are signs and symptoms like fever, myalgia, weakness, itching on the body. So this is actually the secondary stage of syphilis. And why I call it early latent syphilis is that the tests are coming positive, patient has no symptoms. And this has happened within a year of the patient having an episode of syphilis. So that is early latent syphilis. Latent, that means it's not showing any symptoms, and it's early because it happened within a year of your report that has come with you. So that is early latent syphilis. Now what is late latent syphilis? If you ignore, if it goes misdiagnosed, if it's the proper treatment is not given, this syphilis keeps disseminating in the whole body. It doesn't stop. It keeps growing. It keeps going. And then finally it reaches to a place where the patient might have aortic involvement, might have CNS involvement, would start having meningitis, seizures, might be more complications, cerebral edema, neurosyphilis. It's where you will obviously encompass, and you would want a multidisciplinary action. You will call the neurologist. And then there is late latent syphilis. So a patient comes to you, walks inside your clinic and she has no history, doesn't remember ever having syphilis contracted, but a VDRL test is positive. You don't know what was the previous history. You're asking, but she's not able to recollect. She doesn't have any memory of a previous syphilitic episode. In that case, you're presuming that it is more than 1 year old, and you're presuming that either she doesn't know or maybe she had syphilis, but it's more than 1 year, and that is the time you call it late latent syphilis. This thing has to be crystal clear in your mind, because unless and until you know this concept, that anything to follow will not, and you will not be able to understand. Because even my treatment, My diagnosis, everything goes according to this study plan. Timing is important, primary lesion is important, history is very important. Whether she was totally cured, when did it happen, the previous episode, whether she has any memory, whether she did have actually any previous episode or not. It's very easy to label here. In almost all my cases up till now, even the ones which were VDRL positive, usually I have clubbed them in this category and then have given the treatment accordingly. And now we'll talk about the diagnostic test, the non-tripodymal and tripodymal test.